Morning everyone, I am Dr. Geetanjali. Today I would like to present about IC 3D classification of corneal dystrophy and epithelial and subepithelial corneal dystrophies. What is corneal dystrophy? Corneal dystrophies are heterogeneous group of non-inflammatory corneal diseases which are inherited, bilateral, symmetric, slowly progressive, without relationship to environment or systemic factors, and are characterized by pathognomic patterns of corneal deposition and morphological changes. Often we'll confuse with degeneration. Degeneration is the gradual deterioration of the corneal tissue which negatively impact the function of the cornea. The differences between the dystrophy and degenerations are dystrophies are bilateral and symmetrical, whereas degenerations are unilateral or bilateral and are asymmetrical. Dystrophies are usually hereditary, degenerations are sporadic. Dystrophy appears early in life, degenerations appears late in life, and it is related to age. Dystrophies are non-inflammatory and degenerations are inflammatory. Dystrophies are avascular and the limbus is clear and there is clear intervening space of cornea between the deposits. In case of degeneration, it is vascular and there is limbal involvement. There are no clear intervening space of cornea between the deposits. Dystrophies are located centrally. Degenerations are often eccentric and peripheral. Dystrophies, there is rare environmental and systemic associations, and in degeneration it is associated with environmental factors like ultraviolet light exposure and systemic factors which cause oxidative stress. Dystrophies are usually painless except in recurrent epithelial erosions, and degenerations are mostly associated with pain and thinning of cornea. And there are certain exceptions for yes, early in life. Third point. And there are certain exceptions for in the definition of corneal dystrophy. Into the hereditary pattern, majority of patients with epithelial basement membrane dystrophy and central cloudy dystrophy of Francois are degenerative and isolated cases. Those are sporadic rather than hereditary. And there are few sporadic Fuchs corneal dystrophy. Bilateral and symmetric. They can be unilateral also and asymmetric. Example is posterior polymorphous corneal dystrophy. Without relationship to systemic factors, some corneal dystrophies are related to the systemic factors. Example, Schneider corneal dystrophy is where hypercholesterolemia is common, and macular corneal dystrophy where the level of antigenic serum keratin sulfate correlates with the immunophenotype, indicating that systemic abnormalities are integral to the development of characteristic corneal changes. History. Dystrophy is a Greek word which means this means wrong or difficult, and trophy means nutrition. The concept of corneal dystrophy was first introduced by Brunner and Breiber. Later, Fuchs used the word corneal dystrophy to refer to the ophthalmologic disease and postulated that dystrophic tissues resulted from lack of nourishment, hormones, blood and nerve supply. Thereafter, Aftaf and Yoshida continued to use the term corneal dystrophy. Bucklers published the first classification of corneal dystrophy. Although dystrophies can be classified according to genetic pattern, severity, histopathological features, biochemical characteristics, most commonly used traditional classification system is anatomically based. Typically classified by the level of cornea involved, which separates these entities into epithelial and subepithelial dystrophies, common layer dystrophies, stromal dystrophies, sesamus membrane dystrophies, and endothelial dystrophies. Coming to the shortcomings of this phenotypic method of corneal dystrophy. Development of genotypic analysis has revolutionized our knowledge of corneal dystrophy and further elucidated additional inaccuracies in corneal dystrophy nomenclature. Example, genetic heterogeneity. Different genes causing single dystrophy phenotype. KRT3 and KRT12 genes causes Meesmann dystrophy. And phenotypic heterogeneity means single gene that is transforming growth factor beta 1 causing different allelic dystrophy phenotypes like Thies-Bucklers, Thiel-Behnke's, granular corneal dystrophy 1 and 2 and lattice corneal dystrophy. The basis of nomenclature system seems to be more historic than scientific. The new nomenclature had to reflect current clinical, pathologic and genetic knowledge which will be easily adaptable to advances in understanding from the continued discovery of new genes and mutations, and be linked to the old nomenclature for ease of use. So, International Committee for Classification of Corneal Dystrophy. The committee was formed in 2005 and proposed the IC3D classification in 2008, and it was updated in 2015. The traditional anatomical classification continues to organize dystrophies, but there can be an overlap of players involved. Each dystrophy has a template summarizing the genetic, clinical, and pathological information and includes representative clinical images. It introduced categories for identification of genes and chromosomes. Categories indicate the level of evidence supporting the existence of a given dystrophy. Changes in the updated IC3D classification in 2015. The traditional anatomical classification change. The traditionally accepted anatomical level corneal dystrophy has its limitations, as dystrophies were solely assigned to the predominantly affected single layer. For example, Rees-Buckler's corneal dystrophy and Thiel-Behnke corneal dystrophy affect not only the subepithelial layer, but also anterior stroma, and then as the disease progresses, it also involves the deeper stroma. Macular corneal dystrophy affects both stroma and endothelium. Snyder's corneal dystrophy involves epithelium, stroma, and endothelium. The transforming growth factor beta-1 dystrophies affect multiple layers. And in the updated version, they removed the extensive table of gene loci and specific gene location. They excluded the acellular layer dystrophies like common layer and Decimet's membrane dystrophies. They removed Grayson-Willebrand dystrophy. And they reclassified autosomal dominant SHED1, that is congenital hereditary endothelial dystrophy 1, as PPCD, posterior polymorphous corneal dystrophy, and autosomal recessive SHED2 as simple SHED. And they included 3 variants under epithelial recurrent erosion dystrophies. They are Francis-Shetty corneal dystrophy, dystrophia smolandiensis, and dystrophia helsinglandica. Coming to the IC3D classification. They are classified into epithelial and subepithelial dystrophies, epithelial stromal dystrophies, endothelial dystrophies. There are no Bowman layer dystrophies or Decimet dystrophies. Epithelial and subepithelial dystrophy. Epithelial basement membrane dystrophy. Majority are degenerative. And epithelial recurrent erosion dystrophies, which include the 3 variants Franchetti, dystrophia smolandiensis, and dystrophia helsinglandica. Subepithelial mucinous corneal dystrophy, Eastman corneal dystrophy, Lish epithelial corneal dystrophy, gelatinous drop-like corneal dystrophy. And I would be discussing briefly about the epithelial and subepithelial dystrophies. Epithelial and stromal transforming growth factor beta-1 dystrophies, Rees-Buckler's, Thiel-Behnke's corneal dystrophy, lattice corneal dystrophy, granular corneal dystrophy 1 and 2, and in stromal corneal dystrophies, macular corneal dystrophy, Snyder corneal dystrophy, congenital stromal corneal dystrophy, flex corneal dystrophy, posterior amorphous corneal dystrophy, central cloudy dystrophy of Francois, pre-decimate corneal dystrophy. Endothelial dystrophies include Fox endothelial corneal dystrophy, posterior polymorphous corneal dystrophy, congenital hereditary endothelial dystrophy CHED, and X-linked endothelial corneal dystrophy. And they removed Grayson-Willebrand corneal dystrophy. Categories. There are 4 categories. All the corneal dystrophies are categorized under 4 categories. Category 1, the well-defined corneal dystrophy, in which the gene has been mapped and identified and specific mutations are known. Here both the gene and the genetic loci are known and the features are well-defined. In category 2, a well-defined corneal dystrophy that has been mapped to one or more specific chromosomal loci, but the gene remains to be identified. We know only the genetic loci but not the gene. Category 3, it is a well-defined corneal dystrophy in which the disorder has not been mapped to any chromosomal locus. We know neither the gene or the gene loci, but the features are well-defined. Category 4, this category is reserved for a suspected new or previously documented corneal dystrophy, although the evidence for it being a distinct entity is not yet convincing. The features are not well known, well-defined features, and the gene and gene loci are also not known. And the examples for category 1 are CHED early Fuchs, category 2 are late Fuchs and X-linked endothelial corneal dystrophy and LECD, category 3 are sporadic Fuchs, and ERED. And category 4 are predestined membrane dystrophy, subepithelial mucinous corneal dystrophy, and CCDF. Coming to the epithelial and subepithelial dystrophy, first one is epithelial basement membrane dystrophy. Alternative names for it is map dot fingerprint dystrophy, Hogan's microcystic epithelial dystrophy, and anterior basement membrane dystrophy. The category is rarely C1, as majority are degenerative and isolated cases. In few cases, genetic locus is known, that is 5q31. The onset is in the adult life. Symptoms. Mostly they are asymptomatic, but recurrent epithelial erosions occur in 10% of patients due to poor addition of the basal epithelial cells to the basal laminar material. And there is decreased vision and monocular diplopia due to the irregular astigmatism that caused due to the recurrent epithelial erosions. And the severity of pathology can fluctuate with the time. Coming to the signs, there are maps, dots, fingerprints, and blood pattern. Maps. The central or paracentral thickened scalloped circumscribed borders resembling the coastal lines. It is due to thickened intraepithelial multilamellar basement membrane. Dots. They are central round or oval intraepithelial cyst-like lesions containing debris of the degenerative epithelial material. Fingerprints. Paracentral hair-like curvilinear concentric lines seen on retroillumination, and the rib-like intraepithelial extension of the basement membrane. Blood pattern. Subepithelial fibrillogranular deposition. The pictures. The picture A shows the map-like changes, and this shows the intraepithelial dot sign. Both map-like changes and intraepithelial dot signs on the direct illumination. On retroillumination, we observe the fingerprint-like sign and the bleb sign. Diffuse blebs are multiple clouded blebs are seen, and it is called as brawn, and it is only visible on retroillumination. Then the light microscopy, it shows excessive basement membrane material which intervenes between the distorted epithelium and Bowman's layer. We can see the basement membrane extending into the epithelium. This is shown as seen as maps on direct illumination. This on light. This is on Masson trichome stain, and this is on PAS stain. See the maps. I mean, the Bowman's layer extending into the epithelium. Epithelial recurrent erosion dystrophies. There are 3 variants: Franciscis recurrent corneal dystrophy, dystrophia smolandiensis, and dystrophia helsinglandica. All 3 belongs to category 3. That is, features are well defined, but the gene and gene loci are not known yet. On the onset is in early childhood. The symptoms are severe epithelial erosive attacks, commence in the childhood and recur throughout the life. Attacks are usually nocturnal and may cause corneal opacity. In Franciscis corneal dystrophy, there will be recurrent epithelial erosions in the early life itself, in the early childhood itself, and there will be, it lasts up to 7 days, and there will be intervening, and the intervening period appears normal. In the first picture, you can see in the normal cornea. The first decades of life, the cornea appears normal without any dystrophy-specific signs after recurrent epithelial erosions in the interval in between the episodes. With the advancing age, there will be diffuse central haze of epithelial or subepithelial layer develops. On light microscopy, the Bowman's layer is destroyed, and they are partially destroyed, and there will be pannus development between the epithelium and the Bowman's layer. On electron microscopy, we can see the pannus and numerous fibroblasts. And this is a picture of smolandiensis variant, which is a variant of ERED. And in smolandiensis, we can see a central keloid-like opacification. Subepithelial mucinous corneal dystrophy, and it is inherited, and its inheritance is autosomal dominant, and it belongs to category 4, and the onset is in the first decade of life. Symptoms are painful episodes of recurrent corneal erosions, decreased during adolescence. There is progressive loss of vision in adolescence. Signs diffuse bilateral subepithelial opacities and hairs, which occurs most densely in the center. This is a subepithelial mucinous corneal dystrophy on slit lamp biomicroscopy. Central haze and opacity. And on light microscopy, a band of increased staining in the present beneath the epithelium. And the Bowman layer is thin Bowman layer, which is Alcian blue positive. Meesmann corneal dystrophy. The alternative name is juvenile hereditary epithelial dystrophy. It includes a variant called Stalker-Holt variant. It belongs to category 1. The features are well defined and we know the gene and gene loci. Inheritance is autosomal dominant. The genes are KRT3 and KRT12, and the genetic locus is 12q13 and 17q12. KRT12 and 17q12 correspond to the Stalker-Holt variant. And the onset is in the early childhood. Symptoms are typically asymptomatic or may have glare, photophobia, decreased vision, foreign body sensation, and tearing due to painful erosions. Stalker-Holt variant may show severe signs and symptoms with early onset. The Meesmann corneal dystrophy. Direct illumination, and you can see a grey opacity superiorly with distinct border. And in the same eye, on the retro illumination, we can see multiple solitary transparent microcysts. Picture also shows multiple solitary microcysts retro illumination. And on light microscopy, there are intraepithelial cysts, sometimes extruding onto the corneal surface. Contain amorphous material, which is probably the degenerated epithelial cells. The basement membrane is thickened and it is Alcian blue positive. And on electron microscopy, we can see intracytoplasmic fibrillar substance surrounded by tangles of filaments. On confocal microscopy, it shows hyporeflective areas corresponding to the microcyst and some round hyperreflective areas. Fish epithelial corneal dystrophy, alternative name is band-shaped and whorled microcystic corneal epithelial dystrophy. Belongs to the category 2. Only the genetic locus is known, and the inheritance is X-linked dominant, and the genetic locus is XP22.3, and its onset is in the childhood. Symptoms are mostly asymptomatic or blurring of vision if pupillary axis is involved. Signs are whorl-like, band-like, or radial flame-like or feathery gray opacities on direct illumination, and multiple densely crowded cysts on retro illumination. This picture shows feathery like opacities on direct illumination, feathery like radial opacities. And on retro illumination, there are densely crowded transparent microcysts. And on light microscopy, there is pronounced vacuolization of the epithelial cells, particularly in the outer layers. And on electron microscopy, it discloses coalescent intracellular vacuolization of the wing cells, intracellular vacuolization. And in confocal microscopy also shows the intraepithelial hyperreflective dystrophic areas containing hyporeflective rounded structures. Gelatinous drop-like dystrophy. Alternative names are subepithelial amyloidosis or primary familial amyloidosis. Belongs to the category 1, that is the gene is known and the genetic locus is known. The gene is TACSTD2, is tumor associated calcium signaling transducer 2. Genetic locus is 1p32 and the inheritance is autosomal recessive. The onset is in the first to second decade of life. Symptoms include significant decrease in vision, photophobia, irritation, redness, and tearing. This picture shows the gelatinous drop-like corneal dystrophy. It's a band-type keratopathy or mulberry-like keratopathy, and it is fluorescent stain positive. It shows an extremely hyperpermeable corneal epithelium. And this is the comfort-like diffuse stromal opacity due to the massive amyloid deposition in the subepithelial lesions, extending to the mid-stroma of the cornea. Thank you. My references are VEH as et al. 2008. Epithelial stroma.
Good morning, everyone. I'm going to discuss some of the important corneal dystrophies. Epithelial stromal dystrophies. It includes Reese-Burkler's dystrophy, Thin-Beck dystrophy, lattice dystrophy, granular dystrophies type 1 and 2. Reese-Burkler's corneal dystrophy. It is also known as geographic corneal dystrophy. It is autosomal dominant type. The gene involved is TGF beta 1 on chromosome 5q31. Onset is since childhood. It belongs to category 1. It has similar picture as Thin-Beck corneal dystrophy. It should be differentiated from it. In Reese-Burkler corneal dystrophy, it starts since early childhood. Recurrent erosions are more common and more frequent and more aggressive. And initially corneal opacities are seen with clear intervening spaces in case currently extend to the limbus and deep stroma. On light microscopy, the Bowman's layer is replaced by connective tissue band which stains with trichrome red. On electron microscopy, rod-shaped densities are seen which stain positively for keratoepitheliin products of TGF beta 1. And on confocal microscopy, hyperreflective material is seen in the Bowman's layer. Coming to lattice corneal dystrophy. Oh, reader